So our first speaker, Dr. Kevin Petrecca, will be starting off our program this afternoon. Kevin Petrecca, a neurosurgical oncologist, is associate professor in the Department of Neurology and Neurosurgery at McGill University, chief of the Department of Neurosurgery at MUHC, associate chair of neurosurgery at the Department of Neurology and Neurosurgery at McGill University. His clinical practice is dedicated to treating brain cancer patients, and his research program focuses on two main areas. First, studying the origin, development, and properties of brain cancer stem cells, and secondly, developing new tools for brain cancer surgery. So please join me in welcoming Dr. Petrecca to the podium, and thank you very much for joining us this afternoon.
Can you hear me well? Yeah, good. Okay, great. So it's my pleasure to be here. I'm grateful for the invitation from the foundation. I'm going to be speaking about gliomas today, so and I'll get to exactly what I'm talking about. And hopefully, I guess you all have a lot of experience working with patients with low and high-grade gliomas. And my goal is to not share what we've been doing, but some of the things that we will be doing in the future, and hopefully offer a glimmer of hope for this very devastating disease. I'll start off by talking about the different classifications of brain cancer, just so you can link these back to the patients that you deal with. And I'll be focusing on two main themes throughout my talk. One will be the concept of local versus diffuse disease. Historically, glioma has been classified, even for 100 years, as a disease that spreads throughout the brain, and for that reason, it's very, very difficult to treat. And I'll present you some data, some information that suggests otherwise. And I'll also talk about a concept that is very important to all forms of cancer, and certainly all forms of brain cancers, and that is heterogeneity. And the word simply means that cancers are not one entity, one mass, one tumor, but within each cancer there are multiple types of cells, and those types of cells all have their own genetic and genomic backbone. They express different proteins, they respond to treatments in different ways, they have different rates of growth and sensitivities. And that needs to be taken into consideration, and may be one of the underlying factors why we've had such a difficult time treating this disease in the past and presently. And with that in mind, I'll be talking about treatments. And the three types of treatments I'll be discussing today are the three types of treatments that we have, which are surgery, and I'll be talking about new approaches to brain cancer surgery, or guided surgery. I'll be talking about radiotherapy and new approaches to radiotherapy, in this case boosted radiotherapy, and then emerging targeted therapies or targeted chemotherapies and immune modulating therapies that are currently in very advanced clinical trials here and throughout the world. So in the classification schemes, brain tumors is just a very, very large catch-all phrase that basically describes any mass that's growing in the brain. It can be from a brain origin, or it can be from a systemic origin and migrates to the brain like a metastasis. In context of tumors that start in the brain, there are malignant brain tumors and benign brain tumors. Examples of benign brain tumors are meningiomas, vestibular schwannomas, and pituitary adenomas. And in general, these tumors are not actually even in the brain. They're between the brain and the skull. And they're very well treated in general with combinations of surgery or radiation or radiosurgery. On the other hand, the cancers that are in the brain are actually in the brain typically, and the number one of those is glioma, which is what I'll be talking about this afternoon. The second are metastases, which are by far the most common type of brain cancer, and Dr. Pene-Ramon will be speaking about that. And there are other types of tumors. I've just listed medulloblastoma, but these are basically tumors of childhood, which are very devastating as well. Some numbers, these are not exactly new, but the numbers haven't changed in the last 8 years. As percentages of all these types of tumors, this is where glioblastoma sits at 17%, astrocytoma, oligodendroglioma making up less than 10%. When one speaks of glioma, the name just arises from what people thought was the origin of these cancers, which is glial cells, so glio, and then oma simply being a word meaning a tumor. There are basically two types. There's the grade 1 type of tumor, which is called the pilocytic astrocytoma. These are the tumors that children get, some adults as well. And the distinguishing feature between this type of tumor and these cancers is that this tumor grows as a mass. It's not an invasive tumor. It grows in a well-circumscribed way, and when it's completely removed, it's generally curative. On the other hand, these three types of tumors, really cancers, are all invasive. And the difference between the grading, grade 2, grade 3, and grade 4 is simply their rate of growth. Grade 4 is the most rapidly growing, grade 2 is the least rapidly growing. But they're all invasive. And the reason that's important is invasive cancers almost always can never be totally removed because they invade into the normal functioning brain. The way we classify these tumors has changed over the last 10 years, in large help to the Cancer Genome Atlas whole genome sequencing project that started in the United States and was first published in 2008. And this is it's a heat map. It's a little bit of a tricky thing to see and to understand, but I'm showing it only for the simple reason that for the grade 4 types of tumors, each one of these are different mutations. Each one of these lines going across is essentially a different patient, and you can see they have some things in common and some things that are not in common. And the TCGA analysis broke down these cancers into 4 groups based on the appearance of the cells and some of the genes that were being expressed within those cells, and they called them mesenchymal, classical, neural, and proneural. Actually, in the end, this subdivision doesn't make any difference. These patients all respond poorly to our standard Stupp protocol of radiation and temozolomide. But the reason I'm showing it is here. In the proneural category, there are actually 2 very different types of tumors. One is called G-SIMP and the other is called non-G-SIMP. And if you look into the G-SIMP category, you'll see that they almost all have mutations in one particular gene called isocitrate dehydrogenase. And since 2008, all the way up until now, what we've come to realize is that this is actually a different classification of tumor. It's a different type of cancer. These are what people, clinicians you work with maybe, or even you see still quite commonly in the literature, people talk about low-grade glioma, like a grade 2 astrocytoma or a grade 2 or 3 oligodendroglioma. Those tumors all have mutations in IDH1, and they have very few similarities with the rest. So there are really 2 types of gliomas to talk about. There's isocitrate dehydrogenase wild type, which are the classical primary glioblastoma that we all know, that has a very poor survival of somewhere between 1 and 2 years. And the other ones, the IDH mutants that can have survivals ranging from 2 to 20 to 30 years. The IDH wild type tumors generally affect patients that are over 55 years old, and the IDH mutants affect patients that are younger than 55 years old. The IDH mutants respond quite well to adjuvant radiation and chemotherapy, and the IDH wild types don't respond much at all. So keep that in mind. We're talking about really 2 types of gliomas. And the therapies that we'll be talking about, that are the targeted therapies and the chemotherapies, are really all directed towards patients with the IDH wild type gliomas or glioblastomas. So how do we manage these tumors? MRI showing a preoperative ring-enhancing tumor, post-operative MRI showing a resection. Surgery is very important in these tumors, but it's hard. It's hard for a bunch of reasons. One, you can get cancers in every different area of the brain, and depending on where it is, the risk of the surgery goes up or down depending on. So here's a tumor that is in between 2 speech areas and becomes a challenge just because, for example, this patient presented with an inability to speak. And so you can imagine that if you remove only part of the tumor, well, you've got a lot of residual cancer, so the role of surgery is questionable. On the other hand, if you're going to remove large areas, you can be pretty sure that the patient's not going to be speaking afterwards. And so the surgeon is trying to find an area right along that edge, which on an MRI looks to be quite straightforward, but when you're there, it's actually quite difficult. There are no boundaries really between a glioma and the normal brain. It is a diffuse gradient of cells, of cancer cells within the brain. But why bother then? What's the advantage? The advantage is very clear. Since 1997, in the more common use of post-operative MRI imaging, we've realized, and this is what I think is probably still the best study that was done by Walter Tumour, published in 2012, and basically all patients were treated with surgery, maximal surgery, followed by Stupp protocol, adjuvant radiation and chemotherapy. And what they showed very, very clearly was that if you look at the volume of residual tumor the day after the operation, you could see the differences in outcomes. So this solid line on top, this is progression-free survival, or another way of thinking about it is the time to cancer recurrence. The time to cancer recurrence for this disease in general is between 6 and 7 months, and that number has not changed in 15 years. But if you look at the numbers here, 50% time to cancer recurrence is more like 18 months with a complete resection of the contrast-enhancing tumor. The less you remove, the less well patients do. And this not only is a cancer recurrence phenomenon, it actually translates into overall survival. And so instead of having patients dying at 12, 18 months, you can see here, this is all the way to 30 months, greater than 50% of patients are still alive. And if you substratify glioblastoma into those that have no residual tumor and the best biomarker profile, meaning MGMT methylation, you can see how significant and how different the results can be. So there's no doubt minimizing, and more than minimizing, trying to completely resect the contrast-enhancing tumor of a glioblastoma significantly prolongs overall survival. Can the same thing be said for an IDH mutant tumor, like a grade 2 or a grade 3 astrocytoma, or a grade 2 or a grade 3 oligodendroglioma? This can sometimes even be a more challenging operation because the cells have much less of an aggressive look to them. They look much more like the normal brain, and you can even appreciate on this MRI that there is really no beginning and no end to this tumor. It's very difficult to find that edge. We use these sequences as guidance. Our post-operative MRI shows a total resection. We know, well, there's no such thing as a total resection, but based on MRI criteria, similar to IDH wild-type glioblastoma, both for oligodendroglioma and for astrocytoma, if you can completely remove the tumor, you do a lot better. Outcomes are, this is 12 years, this is 18 years. You do a lot better than patients who've had partial, very good actually, this is less than 5 cubic centimeters, so volumetrically, very good, and biopsy only essentially. So the role of surgery is very, very important. Wasn't always known, it's known now. But the challenges still exist for surgeons. Where does the tumor begin? Where does it end? What's actually tumor versus just inflammation? This is an example of a patient with a grade 2 oligodendroglioma who had on his MRI a resection that goes to this little yellow line. Behind the yellow line was not actually removed. 1 month later, with no adjuvant radiation and chemotherapy, that area had disappeared. We don't know what's tumor. We don't know what isn't tumor. MRI is a very, very poor surrogate for cancer. The second question one could ask is, well, if you're removing the cancer completely, where do the cancers actually recur? Where do the failures take place? And this is a study that we did here of 500 consecutive glioblastoma patients who all had complete resections, at least of the ring-enhancing portion of their tumor. These are all the post-operative day 1 MRIs showing total resections. And 85% of the patients recurred exactly at the edge of the resection. So it says to you a couple of things. One, while a post-operative MRI shows a complete resection, we know it isn't because the cancer recurs. And when it recurs exactly at the place where the surgeon stopped. And so wouldn't it be nice to know if you had more residual cancer there or not while you were doing the operation? And so preoperative imaging is imperfect, that's for sure. The conventional guidance techniques that we use during an operation called neuronavigation, essentially, which are structurally based, they lose their accuracy over the course of an operation because the brain shifts. As you remove a tumor or even have a patient in one position for another, there are shifts in the brain, and so your ability to have confidence in this instrument decreases. And lastly, and most importantly, there's no interface between a glioma and a normal brain. And so our goal was to develop a tool that actually could help you with that using a different technology in the operating room that would be fast, inexpensive, easy to use, extremely accurate, and that could actually detect cancer cells beyond what you can appreciate with the naked eye or with a surgical microscope. And this is the tool that we developed. This is work that was done in part here and in part in combination with our engineering, physics, optical specialists at École Polytechnique. Fred Leblanc is the leader of that group. And basically, we came up with this design, and this is actually the major part of it here. This is just a simple guidance tool. And this is called a Raman spectrometer. And essentially what it does is it bombards tissue, any tissue, with light. And the properties of the tissue that are being bombarded will reflect that light back, and you can collect that through collecting tubes. And the shift between what you send in and what you capture is called a Raman shift, and it's a very small shift. It's very, very difficult to detect. But using a combination of nano lenses that are developed by our partners in Florida that we attach basically to the ends of each of these fiber optics. There are 7 fiber optics to collect the signal and 1 fiber optic to deliver the infrared light. And sophisticated artificial intelligence algorithms that can classify the information for you. We embarked on a pretty large study to test if we could actually detect cancers beyond what the surgeon thought was visible. This is just a
Une petite partie de cette lumière va faire vibrer les molécules du tissu. Un signal subtil revient. C'est un effet optique qu'on appelle l'effet Raman. Capté par la sonde, ce signal donnera l'empreinte moléculaire du tissu.
So starting again, imagine that that's the tip of the probe. These are all of the collecting fibers. We're stimulating with one in the middle. This surface here is the brain that may or may not have a cancer. And as we illuminate it, the tissue itself will change the properties of the light. And if you can capture that signal and analyze it in a way, you can learn about the inherent properties of that tissue. And we did that over and over and over and over, and we built a classifier. So we would stimulate the tissue, we would learn what the spectrum that came back to us was, we would analyze that tissue pathologically here with our group of neuropathologists, and then we would make a correlation. And with that, we built a classifier. And once you have a classifier and you do the same thing over and over again, you can start to understand accuracy, sensitivity, specificity. The area we're sampling is quite small. Actually, it's only essentially 1 millimeter deep, and the majority of the signal actually happens at the first 10% of that first millimeter. So we're looking at things at the cellular level, cell by cell. And this is what it's like during an operation. So there was a tumor here. It's been removed. This is essentially the hole that is left after the operation. This is the Raman probe in contact with the brain, and that's us at the very, very beginning, capturing a Raman signal, isolating that piece of tissue, and doing the analysis. And what we found for grade 2 astrocytoma, so these are IDH mutant tumors, we weren't sampling just within the cancer, we were sampling the areas beside the cancer that certainly look very, very normal. So we have histological confirmation of dense cancer or some slightly invaded cancer or normal brain. We did the same thing for GBM or IDH wild type tumor. And what we found after probing 161 different regions is that Raman could predict, and this confirmation was done on histological analysis, the presence of cancer cells at a 92% accuracy, 93% sensitivity, and 91% specificity. Those are fantastic numbers. And this is, by the way, the signal that we get. So here's my disclaimer. I didn't include it at the beginning. This is ODS. ODS is Optical Diagnostic Solutions Medical Inc. That's a company that Fred and I co-founded back in 2015 to develop this for use globally. And this is the interface. And so this is the information you will get back. You actually touch the Raman probe to the surface of the brain or the area you want to interrogate, and less than a second later, you will have a readout like this that basically tells you with confidence intervals, they're not exactly confidence intervals, but they think about them like that, you either have cancer or you have normal brain. It's very rapid. You can use this tens and hundreds of times during an operation. We wanted to push it even further. If we know that radiation and chemotherapy are not curative in this disease, and we know that, that's clear. Cancers always come back in any form of glioma. And they also have profound toxicities. The more you can remove at the cellular level, the better you're going to be. And these are just examples of how precise we can actually get. 83 cells per image, 17 cells, 6. We can get down to 6 cells in a field, which is way beyond what you're ever going to see on an MRI. How far beyond? Here's an example. We took patients with glioma. Each one of these crosshairs represents the area that was interrogated and then sampled and analyzed to assess for the Raman signal and the presence of cancer. If you look at all these crosshairs, you will appreciate that every single one of them is way beyond the area of signal abnormality on an MRI, knowing that all we have as surgeons and radiation oncologists and medical oncologists to understand what's happening with the cancer is the MRI. The blue dots represent positive Raman signals, meaning the Raman said, oh yeah, there's cancer there. The red dots were failures, and these are distances. These are millimeters, so 3 centimeters beyond the T1 contrast, or 2.5 centimeters beyond the T2 or flare changes in an MRI, showing that Raman spectroscopy is much, much more sensitive than an MRI, and to a certain degree helps explain why we're so poor at treating this disease. Imagine you've done a resection over here, removing all that signal abnormality, and you know you have cancer here. This area here will not even get full dose radiation. So when chemotherapies don't work and radiation is either ineffective or mistargeted, it's no wonder that we're having survivals in the range of 1 to 2 years. So to summarize this area, we've been able to develop a probe that is rapid, easy, fast. This costs around $125,000 simply. It can go into any OR. It fits on a trolley that's this big, and you can probe area after area. And it is much more sensitive to an MRI. And it doesn't mean that you'll be able to remove the entirety of a cancer. Of course you won't, because some of these cancers are so large and invasive through the brain that we would never be able to tolerate that kind of morbidity. But certainly you can ask the question, is there cancer here or not? And the surgeon can make a decision, do I remove this or don't I? And this work has been published in prominent cancer and translational medicine journals. So that was done. We're moving on to the next level. We've been to the Food and Drug Administration in the United States. We have an expedited access program for this tool, which means that they're working with us to help us develop clinical protocols that we can actually test to see if this device actually translates into better patient outcomes. And it's an 80-patient trial, and we've done 40 patients as of today. Today, actually, we did patient number 40, and I'm just going to give you an example of a patient who is 25 years old. He's a journalist. He had a seizure. He presented with this, turned out to be a grade 2 oligodendroglioma. Take a few seconds to look at this MRI. That line there represents what the MRI shows to be the cancer, and so the idea would be to try to remove just at that interface. Of course, if you know well that oligodendroglioma is very invasive, you're going to try to remove a little bit more, trying to achieve a super total resection, and that's what we did. And these dots here, 1, 2, 3, 4, 5, represent the space that we were at after I thought we had removed all the cancer. Each of these dots, 1, 2, 3, 4, when they were probed with Raman spectroscopy, showed that there was cancer there. And that was later histologically proven. This point was normal based on Raman, and it was normal based on histology. We then extended the resection to this line. You see the difference? That's about 1.2 centimeters. We probed that area, and there were no cancer cells on any of them based on Raman, and there were no cancer cells based on histological analysis. That's a complete resection of an oligodendroglioma. How long are we going to have to wait to see the outcome of that patient? Well, that's probably going to be decades for him. The important thing for this person is that he's 25 years old. That's a total resection. And in the context of a grade 2 oligodendroglioma, he will not get adjuvant radiation and adjuvant chemotherapy, which is a big deal considering that area of the brain and the toxicity that you get. Moving past surgery, we have radiation, we have chemotherapy. All domains of glioma care can be improved, and I'm going to be telling you about another way. If you appreciate failures are local, failures occur at the edge of the resection cavity margin, what can we do with radiation and chemotherapy to improve those outcomes? So here's, you all know well the Stoop protocol and the way it works. A patient has their operation. 3 or 4 weeks later, they'll meet a radiation and medical oncologist. The decision will be made to deliver radiation and chemotherapy, and the treatments will start. It takes 6 weeks to deliver those treatments. So the definitive radiation dose is given at week 9 or week 10 post-resection. These are very aggressive cancers. In fact, the patient probably developed their cancer only 3 to 4 months before they saw you, and here we are waiting 2 months and 2 months plus to actually give them their treatments. Of course, there's a significant literature that shows that the cancer has repopulated itself. So this is work that was originally pioneered in breast cancer and is now being extended to glioblastoma, and it's called Intra-Go, or Intraoperative Radiotherapy for Glioma. And basically, the concepts are the same. You remove the cancer. No matter what the extent of your resection is, you know there are going to be cancer cells that at the edge that have left and invaded the brain. And you can, during the operation, place an instrument just like this that will actually deliver electrical radiation, so photons, to the edge of the resection cavity, which can do a few things. It actually has a spatial and a temporal advantage. The temporal advantage is it's immediate. You do the operation, you finish the operation, you give the patient the radiation, so you don't have to wait the 9 weeks. The second advantage is the highest dose of the radiation is just around the edge. In fact, it's only 2 millimeters. And so if the majority of your recurrences are happening exactly at the edge of the resection cavity margin, well, here we're augmenting therapies for another 2 millimeters beyond what you can do with surgery. Does it work? This is the time to cancer recurrence, so progression-free survival. Progression-free survival at the treated site. And this is work that was done by essentially spearheaded by Frank Giordano at the University of Mannheim, Heidelberg in Germany. And what he and his group were able to show is that 50% time to cancer recurrence is actually 18 months. In comparison to the global literature of 6 to 7 months, this is a tripling. So that's exciting, and that's a clinical trial that started about 3 months ago globally. We're starting it here now, and we're excited about that opportunity. This is the same sort of thing. This has been going on at McGill, MUHC, for the last over 10 years, and it was a protocol spearheaded by the first author on this paper, George Shanuda. He's a radiation oncologist. He's a partner of Dr. Penny Ramon, who'll be speaking to you this afternoon. And his idea was very similar to everything I've been describing to you now, which is failures occur locally, and the time taken. 6 weeks is a long time to deliver definitive treatment. And so his idea was, how about we start the chemotherapy right away? Instead of waiting 4 weeks, we'll start it 2 weeks earlier. And instead of giving that radiation over 6 weeks, we're going to give it over 4 weeks. So the advantages are those, plus the fact that when you give the same dose of 60 gray in 4 weeks instead of 6 weeks, it's actually an augmented dose. The actual radiation received is more like 72 gray instead of 60. And here are the results. This was a paper published last year, I think. Overall survival, these are confidence intervals above and below, but these are months, right? That is 45%, 40, 35% of patients alive at 5 years, right? The average survival of this disease is 1 to 2 years. These are all patients, including some patients who did not have complete resection. Some had biopsies, and the ones who had complete resections actually are all still alive. In fact, these are all the complete resections. We didn't know at the time how important that was, but there are subtotal resections and biopsies in here. And if you look at the best prognosis glioblastoma patients, those that have MGMT methylation, and I showed you some of that data earlier, you're seeing 50% of patients alive at 5, 6 years. These are incredible. This is an example. This is a patient who had surgery on presented on January the 18th, 2012. Surgery was a week later. That was a complete resection based on MRI, and she has no evidence of recurrent cancer a little bit more than 6 years later. So, hi Valerie. Perfect timing. I'm just presenting some of George's work. So that theme of diffuse disease throughout the brain, it's untreatable by things that we do like surgery and radiation, are wrong. I'm not saying that we're going to be curing these patients, but we are taking survivals from 1 to 2 years and moving them to 5 to 6 years, and that's a big deal. The next thing I want to talk about is with respect to cancer heterogeneity. There's been an emergence in the field of stem cells in all cancers over the last 10 years, and brain cancer has been one of the driving cancers in that area. And the concept of cancer heterogeneity is also well established in all cancers, and certainly very well established in glioblastoma, and I showed you the TCGA analysis. And the point I want to make here, without getting into too much biology, is something that no one would have ever thought 5 years ago in any form of cancer, and certainly not in glioblastoma, is that the cells that are the most rapidly dividing cells within the cancer are not the cells that are the differentiated cells, for example, that are the ones that we're targeting with chemotherapies. They're actually the stem cells, the earliest progenitor form of the cancer. And the problem is that what we have known for a long time is that cancer stem cells, normal stem cells and cancer stem cells, are very resistant to standard forms of chemotherapy. And so the hypothesis has been for a long time that cancer stem cells exist. They divide very, very slowly, and they're the cell population responsible for cancer recurrence. There's some debate about that, but I think most people would agree with that. But more recently, it's emerged that not only are they all that, but they are the ones that are actually rapidly populating the cancer on an ongoing basis, one. Two, you don't have to have a major evolution of the cancer to get heterogeneity. The heterogeneity in the cancer actually develops very, very early within the progenitor pool of cells. So that means that if you are not able to target progenitor cells with chemotherapies or radiotherapy, and you're ineffective at doing that, then you will always have heterogeneity within your cancer, which means that single agent therapies will never work in this disease. So you have two types of therapies. You have chemotherapies, which their goal is to kill all types of cells, irrespective of their nature to a certain degree. Well, those don't work in stem cells. And then you have targeted therapies that are really trying to define one cell with one type of signaling abnormality and mutation. Well, that may work in a stem cell, but there are many stem cells within a cancer that will continually proliferate. And certainly there are many cell types with their own genetic platforms within a cancer. So targeting one population will be good for that population, but certainly not effective for the rest. And these are some concepts that have plagued all forms of cancer treatments, and certainly glioblastoma. So keeping that in mind, it's important to develop enlightened therapies, therapies that can target stem cells, or therapies that take into consideration cancer heterogeneity and figure out a way to bypass it. And I'll present to you some work. These slides were provided by our colleagues from AbbVie. And they actually, this is about epidermal growth factor receptor. People have been targeting that receptor for 25 years in glioblastoma with absolutely no success. But one thing is clear is that maybe you can take the advantage of EGFR amplification to develop therapies that may be able to overcome heterogeneity. And so amplification of the epidermal growth factor receptor is not unique to glioblastoma. It occurs in multiple types of cancer. And all it means is that the gene that encodes that protein is either duplicated or triplicated or more, or there can be mutations within that cancer that are continually driving the signaling of that. But for sure, you will have an expression pattern that if you can target that, will somehow localize, if you can use antibodies, therapies to those cells. And so it's a way of getting different payloads, for example, to the cancer. And that's what they did here. So they took advantage of EGFR amplification. EGFR is amplified in somewhere between 46% of all patients with primary glioblastomas. These are the IDH wild type ones. And this is what they devised. They have antibodies that are very specific at this end here that can target the epidermal growth factor receptor. So when you infuse this antibody into a patient, these antibodies will flow through the bloodstream, cross the blood-brain barrier, and land on the cancer cells. And then they attached drugs. You can attach any drug you like to it, and the one they did was a very classical chemotherapy that inhibits microtubules, which are essential cytoskeletal scaffolding within a cell that keeps its structure, allows different molecules to move around, and certainly helps cells to divide. And so the idea was, if you have patients who have amplification of the epidermal growth factor receptor, and you give them this antibody with this therapy on it, it's a way of giving a toxic chemotherapy specifically to the cancer in a high dose. And so when the antibody drug conjugate binds to the cell, it will bind to the epidermal growth factor receptor. The entire complex will be internalized into the cell. The drug will be released, and through the mechanism of microtubular destabilization, or at least an absence of microtubule formation, you will get cell death. And like in most sort of clinical trials, this was done in quite a large clinical trial in patients with recurrent glioblastoma. Just so you can understand, recurrent glioblastoma has an overall survival of somewhere between 6 and 9 months, and that is evident right here. Here's about 9 months. So these patients either received temozolomide plus, so this is what the molecule is called, that has the EGFR plus the drug conjugate versus temozolomide or lomustine. These are the standard molecules in recurrent glioblastoma. And what they found was, albeit a modest, there was an improvement in overall survival. So that's exciting, but how does that overcome heterogeneity? Well, it does to a certain degree, because that drug can actually liberate from the antibody conjugate without being in the cell. So it's another way of delivering a high volume of drug in and around the area of the cancer. A second exciting approach is an immune approach to targeting cancer. And this is a trial that we have here. Many people have this trial. It's put on by Bristol Myers Squibb, and it's a drug called nivolumab. Nivolumab is an immune modulating therapy. And so immune systems have the ability to attack cancers or not. It depends on which type of cancer. But many types of cancers have essentially a force field that protects them from the cancer. And there are two ways that you can modulate your immune system, or at least that we have very good drugs for. And one of them is, within a person's body, they have antigen-presenting cells, also called dendritic cells, that will bind to the T cells. T cells are the effector cells within the immune system. They have antibodies on them, which when they see a cell, will attack it and kill that cell. In this case, we're hoping that would be a cancer cell. And they have multiple interactions. So this is a protein on the surface of one antigen-presenting cell and on the surface of a T cell, and another one that would be a recognition molecule. But there's a third. And when this protein interacts with this molecule called CTLA-4, this will actually prevent activation of the T cell, prevent it from killing your cancer cell. And so this is work on this molecule has been going on by a person named Dr. Allison from Memorial Sloan Kettering for 20 years. He made an antibody against it that would actually block that interaction and allow the antigen-presenting cell to actually stimulate the T cell. And that work, plus another, I'll just move on and describe this one the same way, because this is probably a little bit more popular nowadays, using PD-1. But instead of having an antigen-presenting cell and the T cell, you actually have these are expressed on the surface of the cancer cell and an activated T cell. And you need engagement of all these molecules to actually activate the T cell. So this is called programmed death ligand, and this is called programmed cell death, one here. If these two things bind to each other, the T cell will not be active. It will not attack your cancer cell. And so you can have antibodies which will actually bind to PD-L1 and inhibit the interaction, or PD. And these drugs are called pembrolizumab, for example, or nivolumab. These are very, very well-established molecules now that are being tested in glioblastoma for the first time in a rigorous way. Very common or very popular in the literature, global press recently, was two major papers published in the New England Journal of Medicine. These are phase 3 randomized clinical trials showing that pembrolizumab, which is a PD-1 blocker, is very effective in patients with melanoma, and similar, same molecule in patients with non-small cell lung cancer. So not only, and this is information that's coming out now, but we've known for at least the last 5 to 10 years that the literature was exciting about these molecules, and that's why it started in brain cancer. And so in glioblastoma, that trial started. There were 2 trials that were started for patients with either methylated or unmethylated glioblastoma. This was the first patient started on that trial in the world. This is his cancer before surgery. This is his cancer after surgery. And so that's April 6, 2016, April 10, 2016, March 14, 2018. This is not recurrence. This is a typical post-treatment change that we see along the edge of the resection cavity in all patients who receive this. I suspect it's from an activation of the immune system causing some local inflammation and scarring that persists, that hasn't changed in 2 years. So if you recall, the time to progression of patients with glioblastoma is 6 to 7 months, and here we are at almost 24 months. Not only overall survival, this is his time to recurrence. He hasn't recurred yet. So that's very, very exciting. So in summary, the point I want to get across is that it's not bleak. We don't have curative therapies for these cancers yet, and we certainly probably will never have one single therapy that is curative. But if you can improve all aspects of care, including surgery, radiation, and chemotherapies, making sure that you're targeting the right populations and take into consideration heterogeneity, meaning targeting stem cells, targeting heterogeneity before it becomes rampant, using a multitude of different approaches, I think we'll be able to make some progress, and I think we have already. Thank you. True. Those don't work, I think. Yes, so this one is available for patients who have methylation of the MGMT promoter, so a certain percentage of patients with glioblastoma. It's still open. It won't be open for long. It's available here. I don't know where else it's available in Quebec. It's available, it's actually not. It's available here. It's available at the University of Toronto. It's available in Vancouver. That's it for Canada, and many centers across the world. The AbbVie trial, this one here has been open for newly diagnosed, so this trial was done for recurrence. It's open for newly diagnosed glioblastoma, and they are at an interim analysis awaiting, so the recruitment is on hold. Am I right about that? So recruitment is on hold, and yeah, so they're analyzing the data that they've acquired already. So that one's not available at this moment. The intraoperative radiotherapy is available now in many centers across the US, and the Raman spectroscopy is only available here.
Happening about the cognitive functions after the operation. For instance, you've been talking about a journalist who, what happened to him after professionally?
Yeah, frontal lobe, very important. One frontal lobe and the non-dominant frontal lobe. And so, yeah, these are all the things that we take into consideration very carefully. As I mentioned, it's important to remove all the cancer, and it's very, very important not to remove normal brain. Certainly at the edges here, you have functional normal brain to a certain degree. It's invaded by cancer cells, but it still works. But we've acquired a lot of information from multiple fields over the last 50 years, understanding what you can and can't do in a surgery. This guy's back at work 4 weeks later. I don't think you could do the same operation on the other side of the brain and certain other areas of the brain. That's why the location of the cancer is very, very important. That's what I was referring to at the beginning. Sometimes surgery can be great. Sometimes there's not very much we can offer. In his case, we could do a good job. Yeah, that's included in pretty much every single major clinical trial. It's included in ours for, augmenting surgery. But don't forget, we think about surgery as being the damaging thing here. Imagine when this person gets radiation. This is what gets radiated all around that edge at the highest dose. In the surgery, we remove the cancer. But the cancer cells invade into the normal brain, and the radiation is to the normal brain. So depending on which area that is, whether it's important for speech, whether it's important for memory, whether it's important for vision, you can see some ticks down and down ticks in function. Certainly, it's the price to pay for survival. But yeah, Olivier, certainly performance status, probably not to the degree that you're looking for, but performance status is included, and most importantly, performance status over a long period of time. Everybody can look good at 3 and 6 months, but how are they behaving at 12 months, 18 months, 5 years? Are they still working? Are they still taking care of their families? Are they still independent? These are all very, very important questions. And they're hard to study.
And what is explained to the patients in those cases for the functional? Because the patient understands, and what happens in their reality is very different from what they expect, first of all.
Yeah, you're absolutely right. And that's a hard thing to do. We take that here at the Neuro, we take that into consideration a lot. And the fact that our weekly tumor boards, we probably spend more time talking about that than anything else in the context of knowing of the toxicities of our treatment. So like I said, the surgery doesn't usually have, if done properly, appropriately, a significant long-term morbidity. If it did, the patient probably wouldn't have been offered a surgery like that, for example. But we take into consideration their performance status, their age, their chronological age, and the health of their brain. Not everybody, a 50-year-old brain is like another 50-year-old, or a 70-year-old is like another 70-year-old. People suffer from hypertension and other diseases that impact the quality of their brain, their ability to receive the treatments, and other therapies they've received. Brains that have received chemotherapies in the past are not as able to receive other treatments. And so, yeah, that's part of the process of informed consent and the experience and expertise of the treating team. And it's something that we think about a lot, and we do our best to give the best informed consent we can to a patient. It's impossible to predict how somebody will behave. In contrast, we are dealing with an incurable cancer, and in general, most patients prefer. I've met one patient in my career, and I've taken care of 1,800 patients like this that said, I would rather die than have any treatments, when they understand, when you really tell them what's going to be happening to them. And so, yeah, our job is not so much to make decisions for patients, but to give them all of the information, and sometimes that's hard to do. But we can, to a certain degree, predict who's going to suffer from profound short-term memory deficits, who isn't, and we modulate our treatments based on it. And there is some literature to support that. In the elderly patient population with glioblastoma, certainly full-dose radiotherapy. I'm not a radiation oncologist, but the literature exists that full-dose radiotherapy often can do more harm than good, and sometimes bringing back that dose to a more tolerable level gives the patient a better performance status, a better ability to handle the chemotherapies, the rest of their treatments, including physical and occupational therapy. So, yeah, we're getting there slowly. Again, hard things to study. There are so many factors in this disease to take into consideration. Yeah. It's by far the best outcome data that exists for this disease. Valerie, help me here. These are patients at risk. This is the second trial. There was a previous trial before. The first trial had 50 patients. This trial has 50 or 60 patients. 50, there you see them there. So yeah, non-randomized phase 2 trial that did not, I mean, it's impossible to put patients into it consecutively because not every patient is a candidate for essentially a stoop protocol. But to the best that we could, patients who we thought would not suffer any ill effects from these treatments, it was on a consistent basis. And it did not take into account, as I said, extent of resection. Yeah, but you're right. That is an incredible, incredible number. Yeah, it's like temozolomide. We really don't know. We follow what was given in the, essentially, what was designated by key opinion leaders or experts to form the basis of a trial. So, for example, the STOOP trial, the temozolomide is 6 cycles or 6 months following radiation chemotherapy. And we're kind of in the same situation with these checkpoint inhibitors. We don't know, what's 6 months, 12 months, but the way the trials are designed, it's ongoing. It's every 2 weeks. Yeah, so they receive that, which is the equivalent of about 40 gray to the 2 millimeter margin, and then 3 or 4 weeks later they get the same treatment that everyone else does because, of course, the cancer is not just at 2 millimeters, it extends, so they'll get the same treatment that you're used to, the same STOOP protocol.
How are they after surgery? Is there like more inflammation?
Yeah, remarkably no. So the phase 1 trial that Frank Giordano and his group did, they did 14 patients, and they did not see any significant post-treatment changes, inflammation. The doses of Decadron afterwards were not elevated. So that was the big concern, and so far it's been pretty good. Yeah, surprisingly. I didn't think it would be like that, but it is. So if you're referring to an IDH mutant astrocytoma that was originally like a grade 2 or a grade 3 astrocytoma, yeah, well, there are clinical trials that are specific to that cohort of patients. So there's actually one that's open right now that we have here. It's a trial that is developed by Victor Levin. It's a drug developed by Victor Levin, who used to be at Texas MD Anderson and UCSF then Texas MD Anderson. And it's for patients with IDH mutant glioma that were grade 3, and they're recurring, and they still seem to be a grade 3 tumor based on MRI. So there's a trial for that. So each trial, it's really important to keep it to consideration of these two classes of glioma, that they behave completely different. In fact, they probably shouldn't even have the same name at all within them. You know, they're very different cancers. And so testing them as one melting pot is not very useful to try to extract information of what works in one versus works in another. For example, temozolomide or lomustine are quite good in IDH mutant cancers, but they're quite poor in IDH wild-type cancers. And so eflornithine is a metabolic inhibitor that may be, at least in early data, quite effective in IDH mutant cancers. So that's one example of. And there are other. These are not large trials. That one's quite large, actually. It's a little under 300 patients. But there are other opportunities, but certainly nothing is as evolved as what happens in IDH wild-type glioblastoma, and that's simply because it's hard to study mutants. Patients live for a long time, and so conducting a study is lengthy, it costs a lot of money, and it's difficult to follow. IDH mutant, absolutely. Sure. Here's, I'll just scroll back. This is not meant to be data on the outcomes of patients with these tumors, because it does not really look well. Am I going the wrong way? Yeah, no. It does not really look well into their adjuvant treatments. This is just about surgery, but these are the outcomes of patients with a grade 2 IDH mutant astrocytoma. These are years. Right? That's going on past 12. Yeah. Not everyone, though. Right? Patients who don't have their tumor removed, these patients all had radiation and chemotherapy, and you can see that survivals are, 10 years, and so the extended resection is a big deal, so it's hard to comment. But in general, yes, the outcomes are certainly not curative, but they're not like glioblastoma. Clinicaltrials.gov is the big American resource with all that information. We have that trial open here. It's also open in Toronto. And a couple other places in Canada, I think. But we have it open as well here, and you can go to our website and see it. Yeah.
And also, if you want to apply for as being one of the patients applying.
Yeah, absolutely. Right. You're welcome.